Hey YouTube, it's Marida and welcome to another edition of the Nurse Lounge. And in this edition, we're actually going to talk about something pretty serious. And what prompted this topic, or let me just first say what the topic is. So we're going to talk about that here in America, that everyone does not get the same kind of healthcare treatment. And so I want to just kind of open your eyes a little bit about the fact that we all don't get the same type of care. And I want to point out some certain populations that do not get the same kind of care as everyone else. And I want you to have a good understanding as to why they don't get the same kind of care. And then on top of that, we as healthcare advocates, as nurses, need to make a cognizant decision and make it impress upon you to do something to be an agent of change in this, in terms of how we treat our patients and things and such, things of that nature. So I've written down, quite a few populations that you may not have even thought of that are considered to be written off by society. So that's kind of how I say it. Patients that are written off by society, or populations of patients that are written off by society that do not get the same care as our counterparts. And basically what we can do about it. And this should anger you. This should anger you that people with the haves and the have-nots and what that demographic looks like. Now, I'm sure most of you could probably guess a few different demographics that definitely are not getting the same kind of treatment. But I want to talk about those demographics in addition to talking about the demographics that you may not have thought about when it comes to healthcare. So I have my book right here. We're going to go ahead and jump right in. So my first group or population is my LTC community, which is my long-term care patients. So think about this. Those who are in long-term care do not get the same type of care that someone in acute care gets. Typically in long-term care, you have your geriatric patients, those who are disabled, either mentally or physically or both. And they have been written off by society. Those are my words, not something I got from a textbook. Because for one, they can't contribute back to society. When you are considered to be elderly, and geriatrics is also on my list as well separately. And I have them separate because everybody who's geriatrics is not in a long-term care facility. Sometimes they're at home or on family members or things like that. Or even in your assisted living facilities where they're not in the LTC side yet, but they are definitely getting help from the same type of workers, so to speak. And I have learned through my clinicals with my students that if my patient or my resident or whatever you call them cannot speak for themselves, they are not going to get the same kind of care that the rest of us get. Keep in mind, I would have to tell my students, I don't care if today is bath day or not, or shower day or not, we are going to offer them a shower today. I don't care what the books say. Tell me, if somebody was to offer you a bath today and you wanted one, would you not take it? So we need to do better about that, especially when, we can do help, when we can help. Now, I do know when you work in LTC and the techs cannot give baths to everyone, every day. I do know that, but I do know that if you're a nursing student right now and you go to these LTCs, they could use your help. And I know you're not there to just give baths all day, but have some dignity and some respect for these patient populations to say, hey, you know what? How would I feel if someone offered me a bath, or if I couldn't get a bath, but I really wanted one? Would you want to sit in feces all day? Would you want to sit in urine all day? Would you not want to be turned and changed and things like that? Keep in mind, if we sit for too long, our butts begin to hurt, do they not? If we sit in one spot for over an hour, our bottoms begin to get kind of numb. So imagine somebody laying in feces and urine and just laying there hours on end, and you're wondering why the skin is breaking down. We have to do better when it comes to this patient population. They've been written off because, again, they can't contribute to society, but they are definitely taking tax dollars in terms of keeping them and medicating them and things like that. So we want to make sure that we take care of these patients, these residents, the best that we can. Okay, my next group is immigrants. You already know immigrants come here to the States. They don't speak the language a lot of the times. Now, right now, I'm speaking of the ones who don't speak the language. The ones who do speak English, they have just as hard a time as the rest of them, but at least they have knowing the language to their advantage. A lot of times you will see immigrants getting poorer care because of the fact that they don't sometimes people feel like they don't know, so therefore they won't know they're getting worse care. Or because we feel like we can't communicate with them well, that we don't provide the same quality of care that we would give to someone who spoke the language. I'm here to tell you this is not an excuse. When I have my immigrant patients who do not speak the language, I make sure I give them just as well as care, as best care as I possibly can, despite the language barrier. Typically, when I'm working at the hospital, the nurses will give me the Spanish-speaking ones because, for one, I can speak some Spanish. And I do encourage you that if you don't know Spanish, because that is one of the main languages here in the States, that you learn some medical Spanish and some basic Spanish just to converse, not to converse per se, but have a basic dialogue if you need to about pain, things like that. So when I do the Spanish, I do know relating to my patient care is more about the bathroom, their bleeding, pain, where their pain is, about food, things like that. Anything I need to basically communicate. When it comes to my assessments and things like that, I typically don't have to, if I do need to use a language line, I will. If we need an interpreter, we will. But for the most part, I understand enough, or they understand enough of the routine on postpartum to know that I'm about to, if I have the blood pressure cuff, they're naturally going to raise their arm out like that for me to put it on there. If I put my stethoscope on their chest, they naturally breathe in and breathe out because they are used to doing that. We often play charades, as I say, where I'll say, I'm speaking in English. They have no idea what I'm saying. Some of them don't. And I say, I'm going to feel your belly, and they'll raise up their shirt because they know that's what I'm about to do. So, you have to make sure that this patient population gets the same type of care that your other patient populations would get. Do not use an excuse, well, I don't speak Spanish. Well, you better get a language line or get an interpreter, or sometimes we have to use apps at work. Maybe it's night shift and you don't have either one of those for some reason. You should always have a language line. But if not, sometimes we have apps that we have to use to kind of look up and kind of, like I say, play charades and figure it out, fake it till we make it. And so I've had to do that before. All right, the next one I have is disabled physically and mentally. You see, this kind of goes with the first one in the LTC. That patient population has been written off to society, again, because of the fact they cannot contribute to society. We spend more tax dollars on helping them with medication, housing, ADLs, and things like that. So they have been written off from society as well. And when you've been written off from society, you don't get the same quality of care as someone who can contribute to society. And honestly, that applies to this entire list right here. They can't contribute, so therefore, we don't, as Americans, don't value them as much as patients. We know they're not going to be able to pay the bill. We know they can't advocate for themselves half the time. So we may take shortcuts with them when we should not be. Children are another vulnerable group. And if they have an advocate for them, like a parent, then they may be okay. But I have seen time and time again at our children's hospital where we don't have, either the parents is not available, or because of the fact that they can't talk, or because of the fact that they're disabled. Same things apply. The children get subpar care. We have to do a better job in assessing their pain and assessing, I impress upon you to learn Erickson's stages as well, and Maslow's hierarchy of needs. You should have learned that in psychology classes or things like that. But no Erickson's stages. What does a 1-year-old need? What does a 15-year-old need? What are they focused on at that age comparatively to the 1-year-old? So learn those Erickson stages, learn Maslow's hierarchy of needs. That's in general for everybody. Nobody worried about paying their bills when they have no food to eat. Nobody worried about paying a credit card when there's no food to eat. So be mindful of things like that as well. Another population is veterans. So these people, veterans, are our people who have worked for the government. They've provided safety and protection for our country. But when they are no longer needed, or when they become disabled, the government and the world writes them off. Now, some of them, if they can advocate for themselves, do very, very well. They end up with other jobs, they get disability. But then there's some of them, as we know, who you see under the bridge, who you see who have PTSD and they can't get any mental help. These patient populations have to be taken care of. So maybe Veterans Affairs or something that you like to go into. Maybe you feel like, okay, I want to do adult health. I want to help a certain group. Hey, veterans need your help. If you're into mental health, veterans need your help. PTSD is very, very, very real. So I want you to think about this group when you're driving down the street and you see tent city, and pretty much every large metropolitan area has what we call a tent city. And is your tent city where this is housed full of veterans because they're homeless, the ones under the bridge. So keep in mind that those are vulnerable populations as well, and they are not taken care of, and they've been written off by society. I want to go ahead, since we're talking about the homeless. All homeless are not veterans, but I also want to tell you that all homeless people don't look like how you think they look. I have met plenty of people who are employed, they're working, but they are truly homeless. They're living in their car. Okay, they're going to gas stations and to McDonald's to take a wash up. And I don't mean just 1 or 2 nights. I mean, this is how they've kept this secret for years. This is homelessness. And then some of these people have children, and these children are out here in the elements, whether it be as hot as it is here in Tennessee or as cold as it can be in New York or Chicago. Imagine children and people being out in those elements. I do know here in our hospital, we have what we call a county hospital. In the county hospital, we see patients all the time who I remember actually was at the county. I want to say it was a hospital. I was still in clinical at this point in time. Brief story time. I was in clinical at this point in time, and as a nursing student, and we had a patient who came in who was homeless, but she came in. I don't know why she came. I don't remember, but I remember she looked so bad. She looked so bad, and she was telling us how she just got off of work, and I'm kind of like, where was she working looking like that? They got her fed, got her cleaned up and everything like that. I'm telling you, everybody doesn't look like a traditional homeless patient or person. But she really just needed a meal. And even though she had been working, she was unkempt, and she smelled bad. And so we gave her a bath, gave her a sandwich, let her have a place to stay for the night. She had chest pains, and they learned what to say. Believe it or not, they learned what to say in order to get them a night at the hospital. They learned that. So they get to stay for the hospital for a night, and then we discharge them, and they're back on their way to do what they were doing. Another one is, we already talked about geriatrics. Ethnic minorities are not treated the same as everyone else. They do not get the same health care as everyone else. And doesn't even make a difference if they have insurance. So these people can have insurance and still get poor quality care. I have a video that I have that you may or may not have seen at this point in time. I'm not sure if I've posted it yet by the time this video comes out. But if you see this video, and I do link it, I will link the two videos together. I had a situation where I would have to say that the patient was African American, and she did not get the same kind of care as our counterparts would get because of, I feel, directly related to what she looked like, her race. Now, is it a conscious decision that this nurse made prior to me? I have no idea if it was conscious or unconscious, but at the end of the day, she was treated poorly. And I don't feel like if her name was something different than what it was, she would have gotten different kind of care. So, ethnic minorities. Plus, when it comes to ethnic minorities, a lot of us are not really a fan of healthcare and the healthcare system anyway. And that's generational. Some of that's just due to us, how we've been treated. We don't trust the healthcare system. And a lot of it is duly noted as to why, and it's very appropriate as to why we don't trust the healthcare system, because you know what? It has done us wrong so many times. If you don't understand what I'm talking about, go look up the Tuskegee syphilis incident. So look that up, and you will understand as to why your ancestors have little faith in the healthcare system. Very little faith. Go look that up. All right. One other one is the indigent population. This is people who don't have any insurance. They are living off the land, so to speak. They literally don't have anything. They typically go to your county hospitals. And of course, in the county hospital, keep in mind, they don't have the same resources as they have in your private hospitals. So the county hospitals run by the government, and they usually are the one hospital that everyone goes to when you are uninsured. And when you are uninsured, and keep in mind, a hospital that's not generating any income means you're not going to be able to afford the best equipment, not be able to afford the best treatment regimens. Oftentimes, ours is a teaching hospital. So sometimes if they're teaching hospitals, you may not get the best care. And I don't say that in a negative way. I'm just saying that if everybody in there is learning, you're not going to get the same kind of care of somebody who is more experienced. Okay. The next one I have is poor pregnant women. So pregnant women in general, but that's a vulnerable population. But if you're poor, especially because you don't always have the same access to care as someone who is more affluent. Now, mind you, if you have poor access to care and you live in an area that you don't have public transportation, and a lot of times these same women have high risk pregnancies, you are not going to get the same quality of care as your counterparts. Here in Tennessee specifically, the ratio African American women are twice as likely to have African American women here in Tennessee are 2.2 times as likely to have a health disparity of infant mortality than a Caucasian woman. So basically, it's 2.5 more times likely that her baby is going to die or be born premature than a Caucasian woman, just because of the fact that she's African American. That is straight to the point. So that's an issue. We have health disparities, and on top of that, we sometimes also have comorbidities that also complicate pregnancies that makes it even worse. So poor pregnant women and also African American women who are pregnant have far worse outcomes than their counterparts. So that kind of sums up my list. There may be other groups of people out there, but I wanted to bring attention to these specific groups because of the fact that my students in general do not think about the fact that, oh, well, why didn't they just go to the doctor? Well, they can't, okay? Or if they can't speak for themselves because they don't speak the language. Or if they can, they don't know their terminology. Or if they can, they don't know when doctors and nurses are being negative towards them or not giving them the correct information because they're trying to get them out the door because they know they're not going to get reimbursed for this visit or for this hospital stay. So we have to do a better job as nurses in being advocates for our patients to say, okay, you know what, even though he or she cannot pay, we have a duty. We took an oath, and we as nurses take oaths as well. And doctors take oaths as well, the Hippocratic Oath, and we take the Florence Nightingale. We do our pledge. It's kind of more of a pledge than an oath. But nonetheless, we are basically saying that we will not do any harm, that we will make sure that we will take care of our patients and things like that. And you have a responsibility to take care of your patients to the best of your ability, no matter what they look like, no matter what. Oh, I forgot about the LGQ. TB, is that how you say it? That community as well. I don't know how I forgot about that. They are definitely not going to be treated the same as everyone else. They're going to definitely have worse patient outcomes because of the fact of, again, what their orientation happens to be. And that should never be. That should never be. It should just never be. So again, these groups are groups that have been written off by society, and they don't get the same kind of care. So now that we've ruled all those people out, tell me who's left to get quality care. Who do you think is left to get quality care? Please comment that. Put that in the comment section down below. Who do you think is there to get quality care? And tell me why you think that. Why is it that certain groups do get great care and certain groups don't? Why is it the haves and why is there have-nots? So think about your politicians. Do they get good health care? Why do they? Do your doctors get good health care? What about your nurses? Do we get good health care? That's a topic for a conversation. Do nurses get good health care? I have to say, if I told you the truth, where I work at, no, they don't. Because a lot of the nurses can't even afford the deductible, let alone by the time they pay the deductible, before they can even get the services they need. So if you're not going in for a well woman exam or for a healthy exam, then they don't basically get the care that they need because they need surgeries that they can't have, but they don't have the deductible because they don't have the money because they're not making enough because of, yes, COVID, everything else is going on. So that's a good question. Do nurses even get good health care here in America? Good question. All right, that's enough of this video. Hopefully you have been provided some insight about what healthcare is like or not like for certain populations of people. Please, I encourage you to like, comment, subscribe. Definitely hit that notification bell so you know next time that I upload a video. Follow me on my social media platform of IG. You will see it somewhere on this screen, and I look forward to meeting you over there. Most people will ask me questions or DM me for video requests over on IG, but feel free to leave those suggestions here in the comment section as well. I do have a business email if you want to get in contact with me for that or other reasons. And until the next time, you all take care. Bye-bye.